Today we're going to be headed to the mission field in Kenya. As you guys know, I'm Dr. Alanna Bree. I am a board-certified pediatric dermatologist, speaker, and advisor for CeraVe, as well as the director of Pedi Derm collaboration. I went to Kenya through a group called Free the Children. It is a nonprofit based out of Canada. And at the time, Valiant, a pharmaceutical company, was offering Passion to Heal grants that provided a way for dermatologists and dermatology practitioners to travel to a fully funded dermatology-based trip to either Kenya, India, Ecuador, and they were so amazing to really help transform healthcare for thousands of children and community members. They not only helped with the health of the community, but they also brought in clean water. We would go to schools and help with the deworming medicine, passing that out to all the children. You know, the clinics were amazing, and the Free the Children clinics throughout the country of Kenya are just so well staffed and stocked, which is not common for this area. And it really was so nice to see the amount of medications that they had available here. And they had received those through different grants and different organizations. World Health Organization, they did have a small lab with a microscope where we were able to look at KOHs and scabies preps. They had just opened up a beautiful maternity area. I was part of a World Health Organization committee where we looked at the ICD code, so the International Classification of Diseases. And that was amazing. I was a representative from the United States, the only US representative, the only female. And it was just so good to sit down around the table and speak with colleagues from around the world and just hear and listen to how they learn. So we're going to jump into the patient cases. And it's important to approach each patient with an open mind, and this is important not just on the mission field, but also in our clinical encounters here in our practices, because we want to avoid diagnostic biases. And we know diagnostic biases come in many different flavors. There's confirmation bias, anchoring bias, availability bias. So the first three are the most common: confirmation bias. So you focus on and emphasize the info that supports your initial hypothesis. So again, some people say it's see what you want to see. And then anchoring bias, this is kind of the red herring. You rely heavily on an initial impression or the first piece of information that you may get. And then availability bias, that's overestimating the diagnosis by how easily it came to your mind. So you know, a more common diagnosis is common, and maybe you've just seen a bunch of cases of this, so that availability bias, you might be over-diagnosing it. And then premature closure, you don't want to make a decision before you gather all this sufficient information. This is another one that happens very commonly just because of the EMR and the copying and pasting that happens as the diagnostic momentum. So an incorrect diagnosis can be kind of perpetuated throughout the patient's medical record without any critical thinking. And then overconfidence bias, this is overestimation of knowledge and skills, and I think sometimes we all fall into this trap. So how do we overcome our diagnostic biases? You know, being self-aware is really important, critical thinking, and then seeking diverse opinions, using the diagnostic tools that you do have available to you, embracing humility, being aware of contextual factors, and then also reflecting on past errors, because when we look at our errors in the past, then we can sometimes prevent them in the future. So going into these cases, we're going to keep an open mind. So here is a picture of a woman that we saw. You can see she has hyperpigmented annular plaques with some erythema. If you got up close, you might see some follicular plugging. We see this on her forehead, around the periocular area, on the malar cheeks, and then in the periauricular, preauricular area. And the diagnosis for this patient is Discoid lupus. We know that that's a subacute type of chronic cutaneous lupus. It usually affects women in their 20s to 40s. It's more common in skin of color. There is a genetic predisposition. There's all kinds of genetic predispositions that have been associated with this. So major histocompatibility complex alleles like your HLA-DQA1 and DRB1, also single nucleotide polymorphisms, interferon, particularly type 1 is a cytokine that's very common in pathogenesis. So there can be mutations in things that regulate the interferon, and then also we know that ITGAM polymorphisms confer a greater risk of DLE than systemic lupus. Some clinical clues. So discoid lupus, your conchal bowl. So Schuster's sign is when we have involvement in the inner ear, the malar area of the cheeks, and then the ear lobule is very common clinical areas of manifestation. Then again, that follicular plugging with atrophy, and very commonly associated with scarring alopecia. So our next case, and I will give you a clue that you wouldn't otherwise see from this photo. So you can see here, you see the legs of someone that has a darker skin type. And we see this kind of what is described as leopard skin with these areas of hypopigmentation interspersed with hyperpigmentation. You can see here a little bit of crusting. And the big clue is this patient is also blind. So Onchocerciasis is the name of this condition, and that is a chronic progressive skin, eye, and neurologic disease. You don't see this here in the United States. It is something that you can see on the mission field because it is a nematode that's basically transmitted by the female black fly bite. And that has also been called river blindness because those worms can get into the eyes and cause the blindness. And then the neurologic symptoms are because of those worms invading neurologic tissue. But the most common is the cutaneous findings. And again, 90% of cases of this condition occur in sub-Saharan Africa, but you can also see them in Latin America and Yemen. The cutaneous disease patterns, there's several. The acute papular onychodermatitis, that's the eczematous rash that affects the face, trunk, and extremities. The most common presentation is chronic papular onychodermatitis, and that's where we get the hyperpigmented papules. They tend to affect the shoulders, the buttocks, and the extremities. Over time, that can become lichenified. We see that commonly on the lower extremities with enlarged lymph nodes. And then you can see onychocerial atrophy, where we start to get wrinkling and dry, thin skin. That tends to affect the low back and the buttocks. And then the onychosomas, and this is the palpable onychocerial nodules. They happen over bony prominences, and this is where all of the adult worms are hanging out. So kind of gross, but part of the disease process. And then the picture that you saw with the patient in Kenya is onychocerial depigmentation, again, sometimes called leopard skin, with your islands of normal pigmentation around usually hair follicles, and it tends to involve the shin symmetrically, as in our patient here in Kenya. And then also other conditions, lizard skin is a term that's used. It's kind of an ichthyotic type appearance to the skin. And then hanging groin, where you get atrophic skin in the groin area with significant lymphadenopathy. So these are all the cutaneous patterns of this condition. And again, you probably need to get on the mission field if you want to see it in person. This is, again, speaks to diseases that we don't commonly see here in the US. You may see on rare occasion, but they are more common on the mission field, and they present at a much more advanced stage. So this is an example of this gentleman. You can see here that he's got a photosensitive dermatitis, involves his face significantly, and then his neck and the V of his chest. And this is pellagra. So that is the systemic disease caused by vitamin B3 or niacin deficiency. We know that niacin, we get it exogenously from our dietary intake. You can get that through animals, which as nicotinamide, and then through plants, which is nicotinic acid. And then our body actually endogenously converts tryptophan into niacin as well. So, we do have endogenous sources, but you do have to have those exogenous sources, which are when, you're on the mission field, people eat very limited diets, and that's where this comes from. And we do see that sometimes here in the US, but again, more so on the mission field. In corn, if it's not broken down, the niacin that is rich in corn is not released. It causes the classic 4Ds: dermatitis, diarrhea, dementia, and death if it's not treated. And the cutaneous findings, this gentleman has very classic cutaneous findings. The photosensitive eruption, again, looks like a sunburn initially, but over time it becomes thickened and leathery, tends to be bilateral with very well demarcated edges, which again this gentleman had. It's on the exposed skin of the face, the V of the neck, the forearms, the back of the hands, becomes hyperpigmented over time. We call that Cassell's necklace, which this gentleman, displays nicely here. And then you can get the Pellagra's glove and boots, where it's very much well demarcated, especially if that's sun exposed over the hands and feet. There can be anogenital and mucosal lesions, so stomatitis, cheilitis, angular cheilitis, genital erosions, and then sebaceous hyperplasia can also form. And then there is a form of pellagra. This is sometimes a board question about Hut-Nip disease or heart-nip disease. It's an autosomal recessive inherited disorder. It's caused by SLC6A19 gene mutation, and it results in impaired absorption of tryptophan from the bowel and excessive excretion by the kidneys. So because you're losing tryptophan, you don't have as much of that endogenous conversion to niacin, and leads to a dermatitis that looks very much like pellagra. So next patient, and this woman had come in. She actually had a skin biopsy because initially they thought this might be DLE. A previous trip and previous team had come in and done a biopsy. It takes many months to get the results back. They have to send it off. And they were debating between Discoid Lupus and what she has, but she came in this time because her sweet little baby here, which you don't really see in the picture, had bad case of scabies. But this is actually an example of cutaneous tuberculosis. And it results from a skin infection with M. tuberculosis. And we know that that bacterium usually initially originates in the lungs and can spread into the skin. But we can get primary cutaneous tuberculosis. So that's one of the cutaneous presentations where you have direct inoculation of the skin or mucous membranes. That develops into a tuberculous chancre, which is a painless, shallow ulcer. Tends to get a very granular base with undermined edges. That affects the face, the hands, the legs, and it's due to trauma, piercing injuries, and then also tattoos. Another common presentation is reinfection or reinoculation cutaneous tuberculosis, and kind of the pathognomonic is lupus vulgaris, which is the kind of buzzword is apple jelly nodules, which you can see, and they have a special, appearance with dioscopy. And then you can also get tuberculous verrucous cutis, which are these warty-looking nodules, and then also orofacial tuberculosis, very common around the mouth and the nose as well. Then we can get more disseminated disease with hematogenous spread. So you can get the miliary types of tuberculosis with very small papules that are disseminated widely. And then you can also get metastatic tuberculosis abscess called gummas. Then we also have another presentation with direct extension, where you have an infectious focus that extends into the skin. This is called scrofuloderma, and it tends to come from an underlying lymph node or the bone, most common in the neck and the jawline. So those are common areas where you get scrofuloderma. And then hypersensitivity reaction, these are called tuberculids, and they develop in patients that have moderate to high levels of immunity, and they're interacting with these the bacillus and causing these secondary skin reactions called tuberculids. So lots of board questions always about tuberculosis. So definitely want to brush up on that. And this patient gave us a good example to talk about that. Now this you will encounter commonly in the US, but you will encounter it more commonly on the mission field, and no matter where you go in the world, you will see this. So this is Tinea capitis, a fungal infection of the scalp, and we know that the fungus invades the hair follicle. It's a deep infection. It requires oral treatment. Topicals alone will not treat this. It involves the skin and the hair predominantly in adolescent children. In pre-adolescent children as well. So little kiddos are the ones that tend to have this. And we know that dermatophytic fungus, so there's hundreds of different types of dermatophytic fungus, but only a very few handful actually cause human disease because they can invade the keratinized tissue. So as far as tinea capitis, you can have endothrix or ectothrix infections. Ectothrix, that's when the dermatophyte grows within the hair follicle and it covers the hair, the surface of the hair, and Microsporum canis is the most common cause of that in Europe and Asia. It gives you a bright green fluorescence, so definitely if you have a case of tinea capitis, you can pull out your woods lamp. You're not going to see it as often here in the US because it's more common in Europe and Asia, but the M. canis, Microsporum canis, which is the vector is usually in cats, is again less common here in the US, but it's always fun to pull out your woods light and see bright green fluorescence with that ectothrix infection. And then your endothrix, we know that dermatophyte will invade the hair shaft and actually grow within it. The most common is trichophyton tonsorians, so T. tonsorians, and that's the most common cause of tinea capitis in the US. And then certainly we have non-inflammatory and inflammatory clinical variants. The non-inflammatory, the most common, that give you the scaly patches that flake off quite easily. You can get little black dots when the fungus is invading around the hair follicle. And then your inflammatory clinical variants, that's going to give you like your carrion, where the body's making a large inflammatory response to the dermatophyte. And then favus, where you get more yellow crusting around the base of the hair follicles. Certainly clinical clues to tinea capitis, not only the cutaneous findings, but alopecia is quite common in children with tinea capitis, and then cervical lymphadenopathy. So there is a paper that's published out there that basically says if you have a kiddo in your clinic where they have scale on their scalp, they have patches of alopecia, and they have cervical lymphadenopathy, that the chance of them having tinea capitis approach about 100%. So again, always important to do a KOH. I think it's important for us not to lose our ability to do these bedside tests as dermatologists. So scrape things often and look at them under the microscope, because we want to continue to be at the forefront of that because we have such ability to help with diagnostic clues at the microscope. And your friends at Sagis will tell you the same thing. Next case. So this is a gentleman, and this is just one example of many that we saw here in Kenya. And this is an example of pretty progressed case of scabies. So we know that this comes from the ectoparasitic mite that's transmitted by close contact and fomites. We do see it not uncommonly in the US. Tends to be more common on the mission field just because some of the risk factors are living in close proximity, certainly being hospitalized, or, in hospitalized type settings. In nursing homes is another place that we see that quite commonly in the US. Causes a very pruritic eruption. The pathognomonic things are the burrows where the little mites are burrowing, can cause nodules. You can put a little bit of ink in those burrows, which happen most commonly on the hands, especially in the interdigital web space. And if you're having trouble finding a burrow, again, you can put just a little bit of ink to track down that. And the mite tends to be at the very end. If you're going to do a skin scraping, that's the best area to go for, is that little dark area at the bottom of the burrow. That's going to increase your diagnostic yield. And then very commonly we get secondary eczematous eruptions. So this gentleman clearly has that as well. You can get secondary impetiginization because it is so itchy and people are scratching like crazy. So they open up their skin, get bacteria in. So sometimes we have to treat the eczema and the impetigo to help treat the entire picture. Clinical variants of scabies, you can get bullous scabies. That's more common in the elderly. You can certainly get crusted scabies, more common in immunosuppressed people. Nodular scabies, and this is when we have a big host response. So we see nodular scabies more commonly in children. And then scabies incognito. So a lot of times, and I've missed it myself, and you will too, scabies can be a good masquerader, but treating it like eczema, and sometimes you need to treat, the eczema to, treat the forest through the trees kind of thing. But sometimes we miss the diagnosis. and treat it like it's just eczema. And again, going back to those diagnostic biases that we went back to, we have to always incorporate new information and not just keep rubber stamping as we go each time a patient comes in. So again, keep your eyes and mind open to what diagnoses can be that we might be missing. Also with scabies, what's really hard, not just in the US, but especially on the mission field, is recurrence is common. It's because the treatment regimen is difficult to comply with. You have to treat not just the person, but you have to treat everybody in the family. You have to treat all the fomites in the environment. And you have to repeat that a week later. But we don't want to overtreat. I can't emphasize that enough. A lot of people will overtreat, and that leads to worsening eczema, and then you can't tell again the forest from the trees. So again, do not overtreat. If you treat twice, that's enough. As far as treatment goes, just some clinical pearls. I do not use topical permethrin if I have someone, especially a child, with a big eczematous response because it burns and stings. So I use off-label oral treatment, and again, that is off-label, but that's the way to go if they have a big eczematous response. But do remind them, no matter what you treat with, that after treatment, the mites will still be in their skin and their body's going to have an inflammatory response to them to degrade them. So their cutaneous symptoms in regards to the rash and also the pruritus will get worse. So, and that's going to go on for about 6 to 8 weeks after treatment. So again, just keep holding their hand through it, tell them it's going to get worse, and then treat the eczema. Treat it with topical steroids, treat it with antihistamines as you would standard eczema as the body is having that inflammatory response. Our next case, a sweet, sweet, sweet baby. This is a very sweet mama that walked probably 6 to 8 hours, I think she told me, to get there that day for her sweet baby. And then she came back to thank me on our last day there. Walked all that way just to thank me because her child was better. So anyway, this is a classic example of transient neonatal pustular melanosis. Also known as transient neonatal pustular dermatosis or transient neonatal pustulosis. It's fairly uncommon, but it is benign. It affects 0.2 to 4% of newborn infants here in the US in their first days of life. It is more common in African Americans. It presents clinically with non-inflammatory pustules with no systemic symptoms. It involves the forehead, the ears, the chin, and the neck most commonly, but also the upper chest and back. You can get it on the buttocks and abdomen, and it can even involve the extremities, including the palms and soles. Pustules are present. They're present at birth, and they evolve. Usually you don't get new lesions. If you're getting new lesions, you need to examine your differential diagnosis. And again, kids with pustules do need to be taken seriously in the newborn period because they can get sick quickly. So again, if they're developing new lesions, you want to have them come back to see you because that should not be if you have given them the diagnosis of transient neonatal pustular melanosis. They then rupture and crust. They resolve over several days. They can leave hyperpigmentation. Again, that's where we get the melanosis part of this, but that does fade within weeks to months and it doesn't require treatment. Another case here, classic example. This is something that we see in the US, but you can also see it on the mission field. This is a good example of lichen planus. It's a chronic inflammatory condition. It affects the skin and mucosal surfaces. It's due to T-cell mediated autoimmune response where inflammatory cells attack an unknown protein in the skin and mucosa. And there are many clinical variants. The most common, the cutaneous lupus, cutaneous lichen planus, is going to be your parasitic purple polygonal papules with PIH, so a lot of P's there. So parasitic, itchy, purple. That is definitely a tip-off on the diagnosis. They tend to be polygonal, and then you get a lot of post-inflammatory hyperpigmentation, Kebnerization, which we know results because of trauma, and you get linear involvement of those papules. The cutaneous lichen planus variants are hypertrophic, actinic when they're more in photosensitive areas, bullous, and also erosive. You can also have significant mucosal lichen planus, and you might have that in addition to cutaneous lichen planus, or you can have that as the primary finding with no cutaneous lesions, lycoplanopylaris, which leads to hair loss. More common and skin of color, then certainly lichen planus can affect the nails. Again, you can have cutaneous involvement, but it can show up on its own, Mycobacterium pigmentosus, and then lichenoid drug eruptions. And it's important to know the list of drugs that can cause that, because those tend to be questions that they like on the boards. Next case, another lichen condition. So this is another patient from Kenya, a young girl that came in. She was actually a daughter of one of the staff members. You can see she has very monomorphic skin color to hypopigmented papules on her arm, and this is lichen nitidus. It's an uncommon inflammatory skin condition, typically occurs in childhood, does have no sex or race predilection. There are several associations, lichen planus, which it used to be thought that lichen nitidus was a subtype of lichen planus, but now we know it is a separate entity. I see it most commonly in atopic dermatitis patients, but other associations includes Crohn's disease, Down syndrome, HIV syndrome, and infections, juvenile chronic arthritis, as well as congenital megacolon. We do know again that you get these monomorphic papules. They tend to involve the arms, the back of the hands, the chest, abdomen, buttocks, but it can involve any site, including the face, and they've also been reported on the penis. Kebnerization, as in lichen planus, kebnerization is also common in lichen nitidus, where you get the linear papules in areas of trauma. Also, oral involvement. This used to not be thought to be quite so common, but we now know that oral involvement is a lot more common than anticipated. And how it presents is with tiny gray-white little flat papules inside the cheeks on the buccal mucosa. And you can also get small white plaques on the tongue and hard palate. And then nail changes, which can be quite variable, are seen in approximately 10% of people with lichen nitidus. The next patient here was a middle-aged woman who came in with these asymptomatic lesions on her legs. They had been treated by the family with an antifungal medicine without improvement, and she was diagnosed with granuloma annulare. And we see this both in the US, but it can happen anywhere in the world. And again, doesn't seem to have a typical predilection. And it's actually probably more common than we give it credit for, just because they do tend to be very localized and isolated and asymptomatic, so a lot of people don't follow up, but they give you this classic annular, kind of elevated, almost infiltrative plaque that's smooth, tends to have a darker center. It's also been called necrobiotic papulosis, and that's because if you take a biopsy, you do see the necrobiotic granulomas. Clinical subtypes, again, most are localized, but you can have generalized. You can also have subcutaneous. That does happen not uncommonly on the forehead and the scalp of children. Perforating and atypical or other ones, and then microscopically you can see interstitial GA, and then more common, in that younger variety, but certainly there are adults that get it, and they tend to get the more generalized variant. So again, granuloma annulare can look very different, so keep your mind open to this diagnosis, because again, the localized ones tend to be more raised and plaque-like, or the subcutaneous are more nodular, and then you can get this disseminated variant. So again, granuloma annulare is again a good masquerader, but keep an antenna up for it. Even on the mission field, it has been associated with things like autoimmune thyroiditis, diabetes, and other autoimmune diseases, hyperlipidemia, and rarely lymphoma, HIV, and solid tumors. And then going on to our next case here, this was just a cute little one-off thing that they wanted to show us. I think this might have been a son of one of the staff members too. But ectopic eyelashes or cilia, and there's all kinds of cilial anomalies, or basically eyelash anomalies that can happen. You can have cilial roll duplication, you can have agenesis, or basically no eyelashes, and then ectopic placement, and those can be anywhere on the eyelid or periocularly, and it is the most rare variant. And depending on the location, it can cause irritation of the eyes, discomfort, and result in corneal ulcerations. But the nice thing is, it's just a one-off kind of finding, not associated with any other systemic issues or findings that you need to be worried about. And then our 3 genodermatoses that showed up in Kenya. Again, rare on the mission field, rare in the US, but you will see these no matter where you're at in the world if you keep your eyes open. So ichthyosis, you can see here that there's ichthyotic scale, very classically distributed on the trunk and extremities. A big tip-off is the clearing of the antecubital and popliteal fossa, which is very common. And this is, you almost need the history to make a diagnosis of X-linked ichthyosis, but it is a rare genetic condition and it is X-linked inherited. So we see this in boys. You get a generalized fine or kind of rhomboid adherent dark gray or brownish scale. And again, it's mostly on the trunk, the neck, and the extremities with sparing of the antecubital and popliteal fossa. It is present usually at birth, but it can kind of take up to about 6 months of age to really clinically manifest. The big associations are corneal opacities of the eyes, undescended testicles, and then they can also have some neurologic abnormalities. It is caused by a mutation of enzyme steroid sulfatase, STS, and again, they like this on the boards. It is involved in the metabolism of cholesterol sulfate in the skin. 90% of patients will have a complete gene deletion, and then because of this, there is low placental STS or steroid sulfatase, and that causes the pregnant mothers to have potentially prolonged labor when delivering an affected infant. Next case is a young lady who is a carrier of this condition. And we see that more commonly with less features and X-linked disorders that female carriers still have a lot of the phenotypes. And, we don't have the genetics on this patient specifically. Could be autosomal dominant, autosomal recessive. But this is a diagnosis that I was able to make from a doorway because of the fact that I was on the National Scientific Advisory Council for National Foundation for Ectodermal Dysplasias. And again, I would encourage everyone to get involved with a patient advocacy organization in some way, be either on their board or their scientific advisory council. It's just a great way to give back to the derm community, but you also get to connect with patients that you wouldn't otherwise in the clinics. And again, I don't think I will ever miss this diagnosis, and neither will you because you're listening to this T4 talk. So hypohidrotic ectodermal dysplasia is one of the 150 inherited disorders in the ectodermal dysplasia umbrella. It's the most common. It causes primary defect in hair, nails, teeth, and sweat glands, and that is what defines an ectodermal dysplasia. You can also have it in other tissues of ectodermal origin, like the eyes, the ears, the lips, the mucous membranes, and also the central nervous system. Again, hypohidrotic ectodermal dysplasia is the most common, and it can be caused most commonly by mutations in EDA, but it can also affect the receptor EDAR or more downstream, and then also been associated with Wnt10 mutations. Again, most commonly X-linked inherited, but can be autosomal recessive or autosomal dominant, depending on the gene mutation. Biggest clinical features are that hypotrichosis, which this patient clearly has, is sparse, thin hair, hypodontia, so can have very few teeth, and the teeth that do tend to come in are conical. And then this has been a misnomer of this condition. So it used to be called anhidrotic ectodermal dysplasia, and this is something that is really not correct. Most people do have hypohidrosis. It's rare to be completely anhidrotic, so a more appropriate diagnostic term is hypohidrotic ectodermal dysplasia. And then a lot of the tip-off that, again, becomes pattern recognition is the distinctive facial features. So the prominent forehead, the thick lips. A big sign is the periocular and perioral hyperpigmentation with kind of a thin atrophic skin, and then the depressed saddle nose. So those are kind of clinical features that we see very commonly in HED. And then last but not very least, this was a kiddo and very pathognomonic here in the photos. You can see the facial involvement, the lips, the tongue, and here the extremity, the buttock, and the hands. as well as the fingers, the fingernails, and the toes and the toenails. So crazy enough, I wrote a textbook chapter on this. It's published in the main Pedi Derm textbook. Never would have expected for this sweet girl to walk into the clinic space in Kenya, but she did. And I was able to make the diagnosis of Discoid congenita. Now we know it's a group of inherited genetic conditions that have manifestations in the mucocutaneous area. And then also because of the genetic changes, it leads to bone marrow failure and then liver and lung fibrosis. But very significant and pathognomonic mucocutaneous signs caused by mutations in a variety of different genes, and they're finding more all the time. But basically, they all affect telomere length, and as far as the severity of the disease, the severity correlates with the telomere length. So the shorter the telomere, the more severe the disease. Can be inherited in many different ways. Autosomal dominant tends to be the mildest form of the disease. Autosomal recessive is somewhere in the middle. And then the X-linked tends to be the most severe. Mucocutaneous findings, most of them are seen before the age of 10 years, but certainly some can develop later, especially the oral involvement. So over time, the nail dystrophy tends to be longitudinal ridging. They can get colonychia, or those thin spoon-shaped nails, and then over time they lose their nails and develop anonychia. The abnormal skin pigmentation is quite specific for this condition. They get this reticulate lace-like hyperpigmentation. It tends to be, over the neck and greater than 90%. Some people call it dirty neck, but tends to be in the skin creases. And then, like you saw in this little girl, she had oral leukoplakia. Other findings can be early hair grain and hair loss, sparse eyelashes, hyperhidrosis, and then they do have an increased risk of cancers, specifically squamous cell carcinoma that can be cutaneous. Those tend to develop in the teens and 20s. About 50% will have a squamous cell carcinoma by the time they're 40, and they can also be found in mucosal sites, including oral cancer. So when you're seeing a patient with the diagnosis of Discoid congenita, it's important not only to do a good cutaneous exam, but do a mucocutaneous exam. And then increased risk of other cancers: oral, airway, GI tract, bone marrow, and lymph nodes. So we were able to let the family know. Unfortunately, not much to do about it, but it did give them answers. And a lot of times our patients, even, though we have to share hard diagnoses, it's sometimes just helpful for them to know what they have. And as dermatologists, we have that benefit of, being able to help make difficult diagnoses and put together a lot of pieces because of the cutaneous involvement. And that is the case with this keratosis congenita. So go out and take good care of all those pediatric dermatology patients. Till next time.